Hello, my name is Dr. Greg Carter, and I'm talking this week on the medical applications of cannabis and its applications specifically used to treat chronic pain. Cannabis and cannabinoids, the active ingredients in cannabis, have been used for thousands of years, and they may be one of the earliest substances used by mankind as medicine. Historically, it has been used to treat pain and was used widely throughout the United States as medicine up until the mid-30s, when it was taken off the U.S. pharmacopoeia against the advice of the American Medical Association. At any rate, over the past several decades, particularly with the discovery of the endocannabinoid system, we now know that cannabinoids are intricately involved in the normal physiological functioning of the human body. They control the sensation of pain, appetite, motor coordination, strength, and interestingly, areas of inflammation and tumor regulation. Also, cannabinoids are known to regulate the immune system and parts of the gastrointestinal system. So cannabinoids are naturally occurring compounds. Endocannabinoids, I should say, are naturally occurring compounds in the human body, and they bind to specific receptors, CB1 receptors in the brain and CB2 receptors in the peripheral nervous system, immune system, and gut, among other areas. When someone takes in cannabis or marijuana into their body, they are modulating an internal receptor-based system. Research in this area is still difficult due to federal regulations, but we are seeing more and more clinical reports of efficacy coming out, and there are now a fairly large number of randomized placebo-controlled trials which are paid for by the federal government, and these trials have, for the most part, shown efficacy in chronic pain. Some of the advantages of cannabinoids over, say, opiates, for example, would be fairly high safety window. And by that I mean there's essentially no LD50 for cannabis or cannabinoids. There's never been a reported overdose of cannabis. And that has to do basically with the distribution of receptors in the body. There are no cannabinoid receptors in the areas of the brainstem that control respiration, which is, of course, what causes problems with opiates when they're taken in excess. Cannabinoids also do not cause constipation. They do not inhibit gastrointestinal motility. Cannabinoids work to treat chronic pain by a different pathway or different set of pathways than opiates. The full delineation of those pathways is still emerging, but I do think the literature would show some synergy with opiates. And one of the ways I've recommended using cannabis to treat chronic pain is in conjunction with opiates, but using lower doses of opiates. Cannabinoids in and of themselves are, I would say, moderately strong analgesic. They are not as powerful as opiates in terms of pain relief. So I also do hospice work, and I would say in terminal cancer patients with severe cancer-related pain, we still rely pretty heavily on morphine and methadone. In someone with, say, chronic low back pain, where you're looking at years and years of use of medicines, I think cannabis has a very powerful role there, and it can be used in conjunction with lower doses of opiates. But you can shoot for getting the best of both worlds there, getting some of the safety and analgesia of cannabis, and then perhaps mixing it with a lower dose of a longer-term opiate. I have had patients that have been on tremendously high doses of opiates and have had them use medicinal cannabis and be able to get down to much lower doses, and in some cases get completely off opiates. I don't always push for that. I push for what's going to be safest and most therapeutic for the patient. If that turns out to be simply cannabis, that's great. But oftentimes I've been able to get people off of huge doses of opiates down to a much more reasonable chronic dose with the adjunctive use of cannabis. So I'm hoping that the takeaway message from my lecture is that cannabis and cannabinoids, the active ingredients in cannabis or marijuana, are most definitely valid to use for the treatment of chronic pain. They have thousands of years of anecdotal use and now have a pretty strong emerging Class 1 and Class 2 evidence base as well. And I would hope that practitioners of chronic pain medicine will embrace these compounds, and certainly in the states that allow it for legal use, to adopt these into their practices, and in the other states advocate for their adoption by those state regulatory agencies.